Hi guys, welcome back. The next topic on the agenda is hereditary hyperbilirubinemias. We'll have a look at some baseline data. You see, once the RBCs in our body will get destroyed in the spleen, there's gonna be production of unconjugated bilirubin. Now, unconjugated bilirubin per se can cross the blood-brain barrier, and the bad news is it can contribute to development of kernicterus/acute bilirubin encephalopathy. So our body will have some safeguard to prevent it from crossing the blood-brain barrier. Well, unconjugated bilirubin is never transported in free format. It is always bound to plasma proteins, and therefore it's not able to cross the blood-brain barrier, and normal people do not develop a bilirubin encephalopathy. This unconjugated bilirubin will then be taken up by the hepatocyte. So there is a special transporter, the name of which I want you to remember is ligandin, and this would be responsible for uptake of unconjugated bilirubin and will help it to transport it inside the hepatocytes. Now, once inside the hepatocyte, there is going to be a enzyme present here by the name of UDP glucuronyl transferase, and this UDP glucuronyl transferase will then help in conversion of unconjugated bilirubin into conjugated bilirubin, which will now be excreted out of the hepatocyte. So just like we were talking about ligandin, which is responsible for intake into the hepatocyte, we have a transporter or transporters which will help in excretion of this conjugated bilirubin out into the bile. Once this conjugated bilirubin will flow into the bile, we have a enterohepatic circulation. Even if enterohepatic circulation is distorted in pediatrics, you read about breastfeeding jaundice. But at the moment, I wanna keep myself restricted to the fact that these transporters that I'm highlighting here before you, which will help in conjugated bilirubin go out of the hepatocyte, is one called as MRP2. MRP2 will stand for multi-drug resistant protein 2, and the second one is called as OATP-B1, that is organic anion transport protein B1. I'll write down the full forms of these subsequently also, but I want you to be familiar with the fact that when it comes to conjugated bilirubin and then subsequently the bile salts being excreted out, it is multi-drug resistant protein 2 and OATP-B1 which are responsible. And well, if you have a problem with MRP2, then the disease that develops in the patient, the first one on the agenda in hereditary hyperbilirubinemia topic and most frequently asked is Dubin-Johnson syndrome. Yes, the same condition where you read about a black liver. Traditionally liver would be brownish or chocolate, but in this case it would be a black color liver. I'll tell you the reason for that also. But if in an exam they ask you defect of OATP-B1, that is organic anion transport protein B1 results in, your answer would be Rotor syndrome, which is a milder variant of Dubin-Johnson also. The clinical differences between the two I'll explain as we progress in the discussion, but at the moment I'm trying to focus on what do I mean by the word hereditary hyperbilirubinemia. Hereditary obviously you understand, but like why is it occurring in a patient is of paramount importance. Now we will focus on UDP glucuronyl transferase enzyme. You can understand if this is not going to work, there would be mainly a spike of unconjugated hyperbilirubinemia developing in a person. If this is going to be absent, well, the bad news is the baby can develop kernicterus, and you have read about this in pediatrics, Crigler-Najjar syndrome, which would be of two subtypes, type 1 and type 2. But at the moment, I just want to differentiate it from Gilbert's. You see, the same enzyme, if the activity of this is only 10 to 30%, let's say we are rating the enzyme at 100 units, only 10 to 30% of the enzyme is active at that particular point of time. Obviously, the ability of this enzyme to perform, that's convert into conjugated bilirubin, will again be hampered, and again unconjugated hyperbilirubinemia will occur in the person. The disease that I'm talking about now, guys, it happens to be the commonest hyperbilirubinemia of the congenital variety. I repeat my statement once again. Gilbert syndrome out of these four is leading the pack when it comes to prevalence. It will have a fluctuating course, a waxing and a waning course of jaundice that I'll explain. But as you can see from this particular discussion that I made before you, the top two conditions, Crigler-Najjar and Gilbert syndrome, they per se would be responsible for unconjugated hyperbil, and the inferior two conditions, Dubin-Johnson and Rotor, will contribute to conjugated hyperbilirubinemia. Once we are aware of this differences, we will now focus on Gilbert's per se. And the usual query that I get from a lot of students is that what should be answered in the exam for the pattern of inheritance, because in some books it is written autosomal recessive, in some it is given autosomal dominant. Well, Harrison has tried to solve this problem by actually mentioning both of them in the following fashion. He has one talked about promoter mutation, second he has talked about missense mutation. So in case you read a question, because nowadays the questions are very specific, so it's not gonna be a vague question. If he mentions regarding the promoter mutation, then you will answer autosomal recessive. You can just remember the R alphabet at the end, no? So autosomal recessive. Missense mutation, well, you will answer this as autosomal dominant. Well, there are various ways of remembering it. I personally find that you can remember some cues. Like I said, it is promoter, so alphabet R coming up, autosomal recessive. And the main problem with this guy is that UDP glucuronide transferase is not functioning optimally. It is functioning suboptimally. It is only 10 to 30% activity being performed by this particular patient. So most of these patients will be having serum bilirubin, which could be in excess of 2 milligram percent. Total serum bilirubin in you and me usually is less than 1. Jaundice occurs when the value goes up to 2 or slightly more than 2. In this particular patient, there's a possibility that hyperbilirubinemia or unconjugated hyperbilirubinemia, to be specific, will be rather having a waxing and a waning course. Like the jaundice part can worsen and can then improve also. Now, why would this unconjugated hyperbilirubinemia vary with time is because this disorder can be affected by stress. It could be physical or mental stress. It could be affected by medication, or for that matter of fact, I can say that fluctuating course of jaundice is the usual profile of these patients. And well, what we can do to reduce this is give phenobarbital. I want to highlight the fact that giving phenobarbital on a long-term basis is not a solution for this condition. Actually, there is no drug of choice for this condition, because if the enzyme is not working, you just cannot use some molecule from outside and increase its activity significantly. And phenobarbital, as you know, is an enzyme inducer, but at the same time, it will have a lot of side effects also. Just to highlight this phenobarbital fact, I want to tell you that one of my students, he had actually appeared for army medical course exam. Like after his MBBS, he wanted to join the Indian Army. So when his medical was done, he cleared everything. I mean, the group discussion part and the viva part, but in the medical, in the interview part, he was perfect. But in the medical part, unfortunately, serum bill came to be high. So he came to me with these reports, and his predominantly unconjugated bill was on the higher side. And he said that I have never had jaundice in my life. I mean, occasionally my mom sometimes said that my eyes look yellowish. I just thought that, every mother is always concerned about her child. So my mom is just saying just like that. But I never noticed that I was having this slight yellowish tinge to my sclera. He neglected that. And he was asking that, doctor, you had spoken about phenobarbital in the lecture. So can I take it so that I can get fitness in the army? Well, I told him that there have been only studies on animals for phenobarbital being used in animals to treat Gilbert syndrome per se. So there are no validated human trials where we can say that, okay, it is safe to use it on a long-term basis. And even if the day you will stop it, because there anyway gonna be side effects of phenobarbital like sedation, etc. So the disease would be back in action. So I advised him against joining the army, because you see, per se stress can contribute to worsening of these patients. So I said, if you are not gonna join the army, you can definitely do very well in all other fields. You can get into private practice, etc. He's doing very well subsequently. But I just wanted to highlight here before you that a doctor, a qualified doctor, if he was not aware of the fact that he's having Gilbert syndrome, you can understand that lots of time this commonest hereditary hyperbilirubinemia will be undiagnosed in ordinary population. So actual estimation of how much caseload is there in India or in any country is little difficult to obtain, because if a person is not going to come to you, you will never come to know the exact caseload. When you give phenobarbital to these patients, it simply results in slight lowering. I'm not saying that the values of serum bilirubin might become perfectly normal. They say that some percentage reduction can be seen, and because of that, the jaundice might transiently disappear or might become milder than what it was initially. So per se, this disorder can be an incidental diagnosis also. Now we will compare this medical disorder with that of Crigler-Najjar syndrome, which is taught in pediatrics as well, and I'll try to focus on the core issues of bilirubin encephalopathy. You see, you are all aware of the fact that the number one cause of pathological jaundice per se, where the baby will become yellow on day one of life, is Rh incompatibility. Like for example, if a lady is B negative, husband is B positive, and the baby is also B positive, then from the second pregnancy onwards, pathological jaundice manifestations can occur. But if he says, what is the leading cause of kernicterus, then don't answer Rh incompatibility. Then your answer would be what I'm explaining to you at the moment, Crigler-Najjar syndrome type 1, where there might be a complete absence of the enzyme activity. Now, when I say complete absence of this enzyme activity, you can understand that the primary problem of this child would be that unconjugated bilirubin will be rising, and soon the values will be so high that the plasma protein ability to catch hold of them will be excited. You see, there's a limited amount of plasma protein, there's a limited amount of unconjugated bilirubin. Both of them bind to each other. Now, the unconjugated bilirubin component is so much that plasma protein is almost limited in the body. It won't be able to catch of every molecule. It will not be able to catch hold of the every molecule of unconjugated bilirubin. So it can definitely cross the blood-brain barrier, and therefore you will read either the term acute bilirubin encephalopathy. Now that's a piece of cake for you, because if you will say bilirubin encephalopathy, you know the diagnosis. So lots of time he might use terms like kernicterus, or he might rather go a step ahead and ask you which basal ganglia can be damaged in this condition. So obviously the damage will be occurring all over the brain, but the basal ganglia that is predominantly affected is putamen. The sequelae, like even if you save this child, lots of time in earlier times when we did not have sufficient technology, lot of these kids never used to survive. But now, because of ventilators and the technology that we have, we are able to save these children. The sequelae or the complication that will develop in this child will be so bad that this child will never be having normal attainment of milestones. He may never smile, he may never be walking, talking, or sitting with support, without support. The traditional milestones that you study in pediatrics would be either delayed or may not be obtained at all. I repeat that, either may not be obtained at all or may be delayed. So what I'm trying to teach you is that the commonest type of cerebral palsy seen in pediatrics is spastic cerebral palsy, but for this kid it's going to be ethetoid cerebral palsy. Why? Because it's putamen that is affected, and I've highlighted that whenever putamen is affected, there could be involuntary movements in the form of ethiotosis. Well, how will he give a case-based scenario here? He is going to describe a newborn baby who's going to be, let me say, day 0, and he has turned yellow. You're aware of the fact that if palms and soles of a baby are turning yellow, that basically means that the bilirubin values are crossing more than 15 milligram percent. Imagine in you and me at a weight of 70-80 kg, total serum bilirubin is less than 1. This little kid on day 0 of life, the serum bilirubin value is skyrocketing to more than 15 milligram percent. The palms of the baby are yellow, the soles of the baby are yellow, and therefore we have decided to give phototherapy today. But unfortunately, in spite of giving phototherapy, no relief. So I have decided tomorrow morning to do a exchange transfusion in this child. But in spite of exchange transfusion, what's going to happen is that when you do exchange transfusion, the values of bilirubin will come down. But subsequently, again, because hemolysis is still gonna occur in the body, there is still no enzyme present in the body of the child. So maybe by the next or next to the next day, the values will again rebound. The baby will again start turning yellow, or in fact, he may not show any clinical improvement. I am telling you that in patients of Crigler-Najjar syndrome, in spite of phototherapy, in spite of exchange transfusion, the jaundice of the child will persist. Now this child is maybe 2, 3 days, 4 days old. This child might start developing extensor posturing, that is called as opisthotonus. That is definitely bad news. Normally you read about opisthotonus with tetanus, no? The child can also start developing seizures. In fact, even if you save these children, in the later part of life, you might be having brown staining of the teeth. That is itself an MCQ, no? Like you study that yellow staining of the teeth can be seen with tetracycline administration. Especially if taken by the mother, the baby can have subsequently, when he has dentition, he can develop yellow staining of the teeth. And brown staining of the teeth is what you read always with kernicterus. That's one of the later manifestations. If the baby survives, if he dies, then obviously that's bad news. But if he survives, you're definitely gonna have a very depressed parent talking about delayed milestones of the child as well. All these manifestations can be written as bilirubin encephalopathy, and there is no cure for it actually, and most of these children can die if proper medical care is not provided. I will now be comparing the manifestations of this particular disorder with Dubin-Johnson syndrome, which is an example of conjugated hyperbilirubinemia. Let's understand the gene involved and the protein involved. Well, because genetics is the in thing nowadays, it's always a good idea to always note down in a register or on a stick-on pad genes and chromosomes, and more importantly proteins related to defective disorders. First of all, you need to remember the name of the gene here, which is called as ABCCA gene. The protein which is defective as a result of it is called as multi-drug resistant. I mean, the name looks very surprising because traditionally in our mind, multi-drug resistant protein or multi-drug resistance is what we read with tuberculosis. But here I'm telling you the word is multi-drug resistant protein 2, or just the word MRP2. Well, what is this MRP2? This is a canalicular protein. The main function of this would be it will help in excretion of conjugated bilirubin into the bile. The hepatocyte has done its job, it produces conjugated bilirubin, but then the problem is kicking out is defective. Because of the fact that conjugated bilirubin will be increased in this patient, you expect that pruritus will be present in this patient, because traditionally whenever I have spoken about obstructive jaundice, whenever I have spoken about conjugated hyperbilirubinemia, I have always said that bile salts will regurgitate back into the bloodstream, there would be pruritus present. But I want to tell you a very surprising finding of Dubin-Johnson syndrome: bile salt and bile acid handling. I repeat that fact: bile salt and bile acid handling is normal in this condition. Well, why is it normal? Is because bile salt and acid handling is not done by MRP2, it is done by OATP. Remember, I told you two proteins which were involved here. One was called as multi-drug resistant protein 2, second was called as organic anion transport protein. So because the problem is only in MRP2 and not in OATP-B1, so therefore only the bilirubin excretion is defective, but per se bile salt, bile acid handling is normal, which explains the fact that why in Harrison or in any textbook they first begin by saying pruritus is not a feature of Dubin-Johnson syndrome. Well, what is the big deal about it is because in all routine cases of obstructive jaundice, which are caused by conditions like colodocolithiasis, carcinoma head of pancreas, primary sclerosing cholangitis, Carolus cyst, choledochal cyst, all obstructive jaundice causes, they will always begin by saying earliest presentation is pruritus, except Dubin-Johnson syndrome, where pruritus is not seen. Why? Because the bile salt excretion in this case is normal. That's because the problem is not with respect to the excretion of the bile salt, it is exclusively conjugate bilirubin that is not getting excreted. The second manifestation is again very characteristic. You see, bilirubin will now regurgitate into the bloodstream. It is being produced in the hepatocyte, conjugate bilirubin. You know it is water soluble. This water soluble bilirubin will not be excreted, so it will regurgitate back into the bloodstream, contributing to bilirubinemia and then ultimately bilirubinuria. Please appreciate the words that I said. I'm going to repeat them again. I said conjugate bilirubin is produced. It's not going to be excreted. It's water soluble, so it's blood soluble. If it comes in the blood, it will be filtered through the kidney into the urine, and therefore these patients will be having a bilirubinuria. And well, the importance of knowing this is that bilirubin in the urine can contribute to a dark yellow color of the urine that is called as mustard yellow urine. Whenever you read this statement, mustard yellow urine, it should always alert you to the fact that he's talking about details of a topic, obstructive jaundice. Well, another way of asking this can be, the characteristic manifestation here is a mustard yellow urine, which can even contribute to staining of the nappies of the child. You see, normally when a child will urinate, the nappies will obviously get soaked with urine, but you dip it in water, the color of the nappies comes back to normal. But if it is bilirubin present in the urine, then it will stain the nappy. So yellow stain will come on the nappies of the child. And even if it does not mention what nappy staining, I just wanted to remember mustard yellow urine is a very characteristic feature again related to obstructive jaundice manifestations. Most of the time, the jaundice that will come in these patients will be related to intake of, let me say, oral contraceptive pills. Like this young lady, she got married, she said, I don't want a baby right now, and a gynecologist has started her own OCPs, and that is when jaundice developed. Or for that matter of fact, it could be pregnancy. You see, there's a possibility we might confuse it with the even fatty liver of pregnancy, but Dubin-Johnson is a separate disorder with deranged conjugated bilirubin, and in fact, in lots of time, the conjugated bilirubin values might be so grossly elevated that you might think that she's having a fatty liver pregnancy. But as I'll explain to you in the workup, you can definitely differentiate it per se from fatty liver or pregnancy. These are the usual presentations. I'll repeat the main salient features once again. The patient is developing jaundice. It's gonna be a conjugated hyperbil, but there's gonna be no pruritus in this case. And yes, there would be a mustard yellow urine present. Okay, coming to the workup of this particular condition, I'll be running a LFT. And the first thing that I will notice is that the serum bilirubin of the conjugated variety is elevated. I want you to remember that if the value in any MCQ of conjugated bilirubin, C's conjugate bilirubin, is more than 15% of the total serum bilirubin, that definitely indicates that this is an obstructive jaundice case. Now you will have a look at the liver enzymes, SGOT and SGPT. Both are going to be normal. SGOT gross elevations are mainly seen with alcoholic liver disease, SGPT with cytopathic effects of viral hepatitis. When you will check the serum alkaline phosphatase of this person, you will be surprised because normally in obstructive jaundice, SAP values are elevated, but in this condition, the SAP values as well as 5-nucleotidase values can also be normal. In fact, that's a surrogate marker for serum alkaline phosphatase. So the bottom line is that had I given you a report in which conjugate bilirubin was also elevated and then the SAP and nucleotidase values were elevated, we could have thought in a standard cholestasis case. But in this particular case, the only derangement that is seen is increase in the value of conjugated bilirubin, which is alerting me to the fact that, well, there could be something beyond the standard cholestasis. Now, I have also decided to rule out other obstructive causes by doing a MRCP in this patient. Since the MRCP report is also turning out to be normal, so I have tried to rule out the traditional causes like primary sclerosing cholangitis, or let me say a stricture or choledochal cyst, Carolus cyst, which could be responsible for conjugated hyperbilirubinemia. The next test that I'm going to do in this guy is very characteristic, and that was the name that I mainly want you to remember, because if there's going to be a question on this topic, then he's definitely going to talk about bromosulfathine test. Now please try to understand what actually happens in bromosulfathine test. You're going to give a IV dye by the name of BSP to the person. In a normal person the dye is cleared. Like, you check for bromosulfathine levels after 90 minutes of giving this injection. In a normal person, the statement of mine is the dye is cleared from the bloodstream by the hepatocytes and then is excreted into the bile. So therefore, after 90 minutes in a normal person, BSP will not be found. But in these patients, it will be obviously taken up by the liver, but will not be excreted. So it will continue accumulating in the hepatocytes and then will regurgitate back into the bloodstream, and after 90 minutes will come back. I'll repeat that again. A normal person after 90 minutes, no BSP in the blood because it is going to be excreted in the bile. Here the problem is in the excretion component. So therefore it will keep on accumulating in the hepatocyte, regurgitates back into the blood, which basically means the fact that there is a defective excretion capability of the liver, which basically means that there is a defective excretion happening in the liver. So do remember the IOC for this condition as BSP test. Additional tests that could be helpful in diagnosis, and they are mostly to trouble you actually, is urinary coproporphyrin values. Now listen to what I say next very carefully, because here a technical aspect is coming up, and if I go into the biochemistry of that, that does not add any yield to your knowledge per se. So you need to focus on some very fundamental issues there. You see, I want to teach you the fact that in a normal individual, CP stands for coproporphyrin. See, in this particular condition, in the urine, the normal coproporphyrin levels in the urine are seen, but there are two subtypes of it. One in biochemistry is taught as coproporphyrin 3, and the second one is called as coproporphyrin 1. I want to teach you that in a normal human being, coproporphyrin 3 is more than 1. You see how to remember it? Number 3 is always coming, or number 3 is always bigger than number 1. Let me just write them in Roman numerals for uniformity. The bottom line is 3 number as a number per se in mathematics is bigger than 1. So remember, in a normal person, CP coproporphyrin values 3 is more than 1, but in the current topic that we're studying, you will always read urinary coproporphyrin 1 values will be more than 3. The total values are normal, but it is 1 more than 3, which is ulta of normal. No, let's take it like that. Mathematics, normally 3 is bigger than 1. Here the reverse thing is happening. This is just to trouble you, because when you read 1 more than 3, 3 more than 1, and the crunch time in the exam with limited time frame, that is where pressure builds up, that us time pe kya pada tha, right? So I would suggest you in this particular topic to definitely remember this data, and I've told you the hack. It is like 3 number is bigger than 1, here vice versa, because pathology always operates opposite of what normal physiology operates. There's a fifth test also that could be written in MCQs and will help you identify that this is Dubin-Johnson syndrome. If we do oral cystography, that is, we are trying to visualize the gallbladder in this case, but the dye that is gonna be used to visualize the gallbladder must be excreted out of the liver, and only then the gallbladder can be visualized. In this particular case, the dye that is used in cystography is not gonna be excreted, so you will always read the statement gallbladder is not visualized. It is always visualized in Rotor syndrome, because there the excreted defect is slightly different. So I want you to remember the specific statements which are of interest to the examiner. Gallbladder is not visualized in Dubin-Johnson syndrome. Copper or porphyrin 1 values are more than 3, whereas normal it is ulta, 3 is more than 1. And BSP test anyway, once I've sensitized somebody 2-3 times in the discussion, nobody gets it wrong. The pattern of inheritance of rotor syndrome is autosomal recessive, and the transporter involved here is organic anion transporter B1, which is gonna malfunction. There are two fundamental differences from rotor syndrome that I want you to remember. First would be that gallbladder can be visualized. Why? Because the dye that is involved here can definitely be excreted. The second is a technical one. If you check for the total urinary copper or porphyrin values, now this is again something which he will love to trouble you with. The total urinary copper porphyrin values are elevated and 1 is more than 3. Remember I told you in a normal person it is 3 more than 1. So 1 more than 3 is still the problem here. But what is happening is that there is a gross elevation in the total values, unlike in the previous case in Dubin-Johnson where I was saying normal. As I highlighted, you can go into the biochemistry of it, but does not increase any diagnostic yields per se. So I would personally suggest you to just focus on the main issues that I've highlighted. And another feature from pathology domain that I can now add to the discussion is that lots of time Dubin-Johnson can be an incidental diagnosis when a person is being worked up, or maybe let me say he is undergoing a surgical procedure like a laparotomy, or he might be undergoing some gallbladder procedure. Black liver can be visualized in these patients. This black liver is mainly because of deposition of which pigment, so it is going to be epinephrine, and this visualization can usually be seen during a laparoscopy or a laparotomy. I mean any kind of surgical procedure. During that, black liver can be visualized in Dubin-Johnson, whereas the color of the liver is normal when it comes to rotor syndrome. So these are some of the salient features that you need to basically compare with respect to the disorders, and maximum questions are asked on Dubin-Johnson. So I would like you to specially get this topic right. And as I've highlighted in the initial part of the discussion, if you just get these basic facts right, you would definitely be able to score these questions. And most of the topic is also discussed in pathology. So a combination with pathology and medicine will definitely ensure that you would be able to score highly in this particular topic. Thank you so much for your patience and hearing me out.